And yes, you pronounced it correctly. So, before we get going, anyone need wine because we haven't had any yet today, so I didn't know if anyone needed any. So, I'm going to present something a little bit different on kind of the journey that we went through with our Connexall installation. We're a little bit different in that we're a little larger, and we're a little bit more complicated than everyone else. So we have some innate challenges that go with that. First, I just want to start with a quick video about who we are and a little bit about the Cleveland Clinic. And the good news is then you don't have to listen to me say it.
Cleveland Clinic opened its doors in March 1921. The clinic building reflected the founders' belief in cooperative medical practice, research, and education, with space dedicated to each activity. The success was immediate. Over the next several years, a new 240-bed hospital and research annex were built. Founder George Kreil led the way. He was a skilled surgeon and outspoken public figure. An honorary member of the Royal College of Surgeons of England, he had an international patient following. In the 1950s, heart care became a major medical focus. Cleveland Clinic cardiologist F. Mason Soames discovered a new way of imaging the coronary arteries. Coronary angiography pinpointed blockages and confirmed that heart attacks were caused by coronary occlusion. This discovery led to a second breakthrough. In 1967, a young clinic surgeon named René Favellaro performed the world's first coronary artery bypass procedure. These synergistic discoveries launched the modern era of heart care worldwide. The clinic grew rapidly in the 70s and 80s. To help manage its growing complexity, the clinic instituted annual professional reviews for all staff physicians. This commitment to measuring performance distinguished them academically from all others, and the data set standard practices. Cleveland Clinic built 18 family health and surgery centers in surrounding communities. Through mergers, it acquired a system of 8 community hospitals. In 2002, the clinic founded the first new medical school program in the U.S. in 25 years. The Cleveland Clinic Lerner College of Medicine, now tuition-free, uses a unique curriculum specifically designed to graduate a new generation of physicians skilled in both scientific research and the practice of medicine. Today, Cleveland Clinic has grown to 43,000 caregivers with 3,000 physicians and scientists in 120 medical specialties and subspecialties. It is the second largest group practice in the world, with facilities extending well beyond Cleveland, Ohio. Cleveland Clinic, Florida includes an integrated hospital and clinic in Weston. The clinic also has health and wellness centers in West Palm Beach, Florida, and Toronto, Canada. The Lou Ruvo Center for Brain Health in Las Vegas is specially designed to advance the research, early detection, and treatment of neurocognitive disorders. Internationally, Cleveland Clinic partnered with Mubadala Healthcare to build a full-service hospital and a specialty clinic. It also manages Abu Dhabi's Sheikh Khalifa Medical City. The clinic's footprint is becoming increasingly global, with eCleveland Clinic and the transmission of electronic medical records. A new era began in the fall of 2008 with the opening of the Siddell and Arnold Miller Family Pavilion and Glickman Tower at Cleveland Clinic. These two buildings house the Miller Family Heart and Vascular Institute and Glickman Urological and Kidney Institute. Together, they add more than 1 million square feet to the Cleveland Clinic campus and help meet the demand of an aging population for these services. The next frontier is patient experience. Cleveland Clinic is the first major medical center to be organized around patient-centered institutes. Each institute combines clinical services addressing a single disease or organ system. For example, the Neurological Institute unites neurology, neurological surgery, and psychiatry under one roof. This integrated model of care is supported by a culture where engaged caregivers provide an exceptional experience for patients and families.
As I look back, I see this incredible dedication of the people who started this place and the obligation that we have to pick the torch up and run with it. this is a big responsibility. And you add that responsibility to the responsibility we have for looking after people. Everybody who walks into the hospital is terrified and needs to be taken care of in a personal way. We're all going to be patients, and we want them taken care of like we'd like to be taken care of. It's all about patients. And I think that's the centerpiece. And from that, you get a sense of the privilege of looking after people and the responsibility that goes with that.
So that's a map of kind of where we live in Northeast Ohio. So you can see that we have many regional hospitals and also a main campus. And as a result, we do segregate ourselves as the east to west to central health system, although we are really one roof. And that was some of our, in our journey with Connexall, that definitely came into play. A couple of stats about the clinic, 5.1 million visits in 2012, 43,000, actually almost 44,000 caregivers. We have about 1,000 IT staff, so fairly large representation to that. Again, we're nationally and internationally present in healthcare. Also, we adopted Epic. We are pretty much complete, at least for now, with our Epic implementation. We also offer MyChart to all patients that come in, so you can access your medical records remotely. So one thing I want to add, this next slide is a little bit busy, but it really goes to where healthcare is going. I mean, we are really going from a volume-based to a value-based healthcare delivery system, and it's forcing us to do more with less and employ more and more technology. So Connexall has definitely helped us with that. So our initial installation at the Cleveland Clinic was at one of our community hospitals. It was in a NICU, a 20-bed NICU with the GEB 850 monitors, and we've also subsequently added nurse call to that in Hillround. So the next challenge, or the challenge that I face from my side of town, is, well, I'm sorry, I'm getting ahead of myself. So we had one server. It was at one of the community hospitals. I work on the other side at another community hospital. So it was serving the NICU well, but we had an enterprise need then. And the enterprise need was a new ED and ICU that we built at the hospital that I currently work at, 38-bed ICU, 44-bed adult and peds ED, and we wanted device integration there too with our nurse call and our Philips monitoring systems. We also had two other hospitals, and some of the institutes started looking at device integration for their needs too. So we started saying, okay, we have this server at the one hospital, and it's active obviously, and we're monitoring everything. And how do we operate on the airplane as we're flying it, which is essentially what we started thinking that we had to do. So we had 3 upgrade options to go with. One, simply just leave that server there, connect Fairview to it, and go for that. But we quickly realized that our traffic would be passing through our data centers, additional hops, and then how do you take that into a more enterprise application? So we quickly came to the conclusion that although it would work, but it would be more WAN hops, and it really wouldn't get to our main objective of making it a true enterprise application. So we took a look at another option of, should we go with a regional approach? Should we go with the east, west, central servers? And we quickly realized that, if we're going to do that, we're really going to share alarms and whatnot across the enterprise. That probably wouldn't work. Adds a lot of manpower, a lot of servers, a lot of cost, which is contrary to where we're going in healthcare right now. So we quickly figured out that that probably wasn't a real great idea, and then we brought Ed McNeil in from Connexall and really started looking at some plans. And I can't say enough about them. I can't say enough about the team, because they really were able to walk us through a very complicated scenario, in that our NICU, obviously we couldn't take our alarms down, and yet we couldn't have downtime, but we needed all these other hospitals coming online. So what we looked at doing, we came up with a plan. We implemented a server at the main data center. We failed the installation over to another server. We had 15 minutes of downtime. We maintained all of our alarms, all of our history, and we look a lot like this now, with the alarms going directly into the data center and out. So what this has now been enabled us to do is, now we can take alarms and we can monitor them anywhere. So we are doing a lot of, we have a clinical monitoring that's done remotely. More and more nurse calls, bed assignments, everything is done remotely, because everything is going to, one desk basically. So that's kind of where we're at today. And one of the things the clinic is known for is innovations. And one of the things that we've done, and I brought Connexall in to help, is we're now looking at monitoring our ICUs remotely. So we started looking for e-hospital, e-ICU solutions. We quickly realized that what we wanted to do wasn't out there. So we wanted to be able to watch and predict patients within the ICU environment. And the difficult thing is we don't have enough intensivists, we don't have enough nurses to staff them 24/7 the way they should be. Any intensivist or any mid-level provider, they're in high demand right now. And, getting true 24/7 coverage in our high acuity areas is becoming more and more difficult. So what we want to do is, have a safety net for the bedside caregivers. Predict if a patient is going to have an event before it happens. And then also to be able to, improve outcomes and cut length of stays within the ICUs. So we started looking, like I say, at some e-ICU solutions out there, and we quickly realized we didn't have what we needed. They were very expensive. They don't have direct integration into the EMRs. They didn't have integration into our waveforms, into our, our PACS. So we started thinking we can build a better wheel, and that's what we've done. So the capabilities is really, it's a secondary monitoring. So a lot of the caregivers, a lot of the nurses were saying, wait a second, I can manage my patient just fine, and I don't want Big Brother looking at me and second guessing what I'm doing or something like that. So that was a big hurdle for us. Again, we wanted full integration into our EMRs and our MARs and imaging and whatnot. And we also wanted two-way communication into the rooms. So we wanted to be able to see the patient, talk to the caregivers, and nothing like that was out there. So what we did is we created a system that will put all of the patients up on a board for a caregiver that's remote to start monitoring patients. And you'll see different colors there. You have the red patient, which in our decision modeling is your highest acute. They may not be the sickest, but they have the highest probability of having a bad event. And these tiles actually start dancing around because it's real time. So that red one may go to green, and the green's going to go to red, depending on what's going on with the patients. So, you have the high-risk patient, you have the low-risk patients, we can hide them if it gets too busy. Right now, we're looking at one person watching 40 patients as a secondary, so it can be busy. And then if you have some patients that are of interest to you, you can pin them at the bottom, and that way the tiles won't dance on you. So this is a picture of the EICU. So you can see the one screen. You notice the 4 other monitors, and with a click of a button, you can bring up your epic, your films, your waveforms. With another click of the button, you can bring up the camera, so you can see and communicate either with the patient or the caregiver. And actually, they're so good that we can actually zoom in and look at a smart pump to make sure the settings look good, or make sure that you have the correct bag hanging off that smart pump. So it's your typical pan zoom tilt voice or IP based camera. And then from the perspective of the patient, we will take the TV and we hijack it. We'll turn it on, we'll adjust the volume, and then they can talk to us and we can talk to them. So, pretty neat stuff. And then you can see that there is a small button underneath the television. It's called the doorbell, and we let the patient know when we're looking in. So it'll go from flashing to a blue, or a caregiver can push the button and say, hey, I have a question. You might have a younger nurse at night. So typically, your third shift is your youngest, less seasoned nursing. So they can push the button and say, hey, I have a question, or what's our standard operation for this, or I have a question like that. The younger nurses really embrace this. The older ones, not so much. They don't appreciate it. So right now in our pilot, we're doing a 7P to 7A rotation only. And I've seen it in action. Right now we have it at just 4 beds, and we're actually next month we go live with 3 more ICUs. It's incredible. It's absolutely incredible to me that with technology we can look in and monitor and predict things before it happens, because ultimately, everyone knows that an event happened afterwards, but if we can predict it beforehand, that's pretty incredible stuff. So the capabilities, again, your primary patient monitoring isn't changing. Your bedside caregiver is still there, but we're providing the staff with a secondary monitoring and notifications. Patients aren't viewed continuously, and nothing is recorded, which was a concern for a lot of folks. So when I started talking to the team and the innovations team, and they rolled out the pilot to one of my sites, and we went to see the command center. They were talking, and they said, we don't know how to call the caregivers though. We don't know. We can call the room, but I don't know how to call. And I said, I know how to communicate with caregivers. That's easy for me. And I said, we can build a button, and we can use Connexall, and then we can talk directly to the nurse or the doctor or the RT without having a person sitting anywhere from 2 miles to 20 miles away wondering what the nurse is for bed 1 ICU at Fairview. I said, we can do that. So what we're going to do now is, with a click of a button, off that screen, start talking to the nurse before the nurse is even aware that they're seeing an issue. Our ICU at Fairview is about the length of a football field. It's 84 yards long. So you can imagine if you have a nurse on one side, you're caring for a patient at the other end, or they're somewhere else in the hospital, that can be quite a long walk. You could see an event, or an event could occur before that nurse would know, or you see alarms going off. This way, we're going to have somebody at the hospital click a button, bring the patient up, bring them on the screen, and be able to talk to that caregiver, whether it's on a Vocera, which is what we have, or a VoIP phone, which is what's on main campus, or an iPhone, or whatever we program it in, we'll be able to, via Connexall, connect all of these devices together, and with one click, be able to talk to the caregiver. So, pretty neat stuff. Yeah.
Is it on the computer talking to the person, the nurse? They recognize him. Who's the one that communicates with the nurse?
Well, we have an intensivist. There's one physician there, and there's 2 mid-level providers. So yeah, it's not a tech. I mean, this is.
They can give orders over the phone then?
They could. Yeah, that physician could give orders, and they have access to Epic, so they could. We don't do voice, or we don't do verbal orders. Correct. Right. Exactly. Yes. And I mean, you can extrapolate this out. The clinic is very good at spinning companies off. So I can see this one being offered as a service. If you have a high acuity patient, in North Dakota, and they don't have a high level ICU, but to be able to have an intensivist at your beck and call would be a nice service, I would think, for a very, especially in your critical access hospitals, in your smaller hospitals, because you can't really afford to have an intensivist sitting there in your ICU. That answer your question?
Yes.
So I'm going to leave you with another video. I have a really good marketing department, you can probably tell. We often lose sight of why we do things. And, we talk about alarms, and we talk about servers and IP and WAPs, but at the end of the day, we're here to serve our patients. And I want to leave you with a video that demonstrates that a little bit. So with that, just click it and you can do the sound. Then I'll do questions afterwards. So it's a little long, but I think it kind of demonstrates why we're here and why we do what we do. So with that,
You ready for questions? Yeah?
I'm ready for
We have some time. We have about 15 minutes if you have any questions. Put up your hand and I'll walk to you with a microphone. There you go.
My name is Antonio Marquez. I'm an anesthesiologist, and I'm the director of Women's and Children's Hospital at the Centro Hospitalar de Porto, which is a major teaching hospital in Porto, Portugal, where port wine comes from. And I was listening to what you have to say, and I'm not criticizing. I really don't have a question, I have more of a comment. On one hand, I'm fascinated with all the gadgets and all the possibilities that IT solutions now can give us. But on the other hand, as a doctor, and before my current place of work, I was the director of anesthesia and intensive care services in my hospital for 10 years. I'm a bit afraid that maybe we're going a bit overboard, because no matter how much technology you have, none of this will substitute the presence and the good sound judgment of the nurse next to the bed and of the doctor in the ward. And there's got to be a limit, because one thing is having technology as a tool to help you, and another thing is having technology as something to substitute you.
tethered to a microphone. I 100% agree with you. And in talking with the nurses and talking with the physicians, I had a discussion with a friend of mine that's a physician. I said physicians are starting to become statisticians. We look at a report, we look at a spreadsheet, we look at probabilities. And he says, I practice medicine. That's what I do. So yeah, I agree with you 100% that you can't over rely on the technology, but what the technology is enabling us to do is to put that second set of eyes on a patient, or to put eyes on a patient that otherwise wouldn't have that expertise at a hospital that doesn't have an intensivist and whatnot. So on one hand, I completely agree with you. But on the other side, that we're just offering a safety net to the caregivers.
Very good. Any other questions? No other questions? Okay. Thank you, John.
Thank you.